Now here, it's my pleasure to introduce the next speaker. Is a wonderful neurologist who gets it now. Earlier was ill and younger, and before he got healthy, and the same can be said of Dr. Elsas. He's a wonderful neurologist who gets it, and we need to get more neurologists that learn to do this technique. Dr. Elsas is a fellow at the Friedrich Hussmann Hospital for Integrated Psychiatry in Butenbach, Germany. Came all the way from Germany for this weekend, and an internationally recognized expert in the treatment of epilepsy. Dr. Elsas served as an assistant professor at Oregon Health and Sciences University, where he conducted pioneering research into electrophysiology and sensory perception, including an examination of the triggers of epileptic seizures. He studied neurology at UCLA and served as a postdoctorate fellow at the University of California, Berkeley. As a practicing physician, Dr. Elsas has spent years treating patients with the Andrews-Reeder behavioral approach, combining these behavioral approaches with EEG and heart rate analysis. Dr. Elsas has been pushing the Andrews-Reeder technique to the next level, in the process helping numerous patients address their seizures. In 2005, the National Institutes of Health honored Dr. Elsas for his research with the Mentored Patient-Oriented Research Career Development Award. Let's welcome Dr. Elsas.
Thank you, John, for the kind invitation and introduction, and also for organizing this wonderful conference. I really appreciate the opportunity to talk here back on this North American continent that I left just in December last year. So the question I want to address is a bit more from the scientific perspective. Is self-control of epileptic seizures possible? How does it work? Mind over brain. Can we understand this from the physiologist, from the doctor's perspective? Well, we really need to start looking from the patient perspective to be able to say anything about those questions. Considering what is an epileptic seizure, it's a sudden loss of self-control, and with it, a loss of the essence of our humanity. Because conscious awareness and self-control are essential features of being human. So epilepsy is really a disorder of consciousness that strikes at the essence of our humanity. And furthermore, as Josh was showing us so vividly this morning, it can strike any time. So it brings with it a profound sense of loss of control over one's life, which often results in depression and disengagement, which really prevents most people with epilepsy from getting well, and resulting in a dependency on medical care and doctors, an attitude of please fix me, that is really counterproductive. So to get over this, we need to see that there is really two different perspectives that have equal rights. Not only the physician's perspective, who considers themselves the only ones that are objective and scientific. The patient's perspective is equally important, or more important, the subjective experience, which is commonly considered to be unreliable. Because as a patient, we experience the loss of control and the loss of consciousness, where the neurologist only sees evolving rhythmic electrical discharges that seem to arise seemingly out of nowhere, arising randomly. Well, with this approach, we can do away with that. It's really actually unscientific to say that seizures arise randomly. It's just a capitulation. It's a leaving out of essential facts that just have not been explored so far in a sufficient manner to really say something about it. So if your neurologist discounts that there are triggers, you have to tell him, look again, look at the facts, read the papers, and I will cite many of them for you. Both perspectives are needed to investigate the self-control of epileptic seizures and can lead us to a new understanding of epilepsy and the relationship between brain and consciousness, which is a very fundamental question beyond epilepsy. But epilepsy really is at the core of it. Many epilepsy patients believe it is possible to interrupt seizures. In a study by Reina in 1997, he found that 20% of 562 patients attempted to interrupt the development of their seizures, and about 10% of them felt to be partially successful. Fenwick in 1994 found that 22 to 28% of 76 patients reported they could generate their own seizures, and 36% felt that they could sometimes stop them. Here's an example that has been published already in 1956 in the very respectable journal Brain by neurologist Dr. Efron. The patient was a 41-year-old female singer who had complex partial seizures since age 15, which generalized to a tonic-clonic seizure with every single time that she had an aura. And she had 7 to 18 seizures a month. Phenobarbital and phenytoin, the most effective drugs at the time, proved to be no help. Her aura began, and this is helpful for us to learn, really to observe more closely, really what is happening at the beginning when we still have a chance to do something. She first sensed that things were turning unreal. She was not herself anymore. And then she had the thought, I'm going to smell something. And this was followed by the sudden onset of an unpleasant, sweet smell. Then she seemed to hear a voice calling her name, coming from the right side, accompanied by an urge to follow the voice and turn to the right. But she knew that if she followed that urge, she would lose control and the seizure would invariably result. So she always tried to resist that urge, but she could never make it. So she would get into the clonus of the right arm, the rhythmic shaking, followed by the generalized convulsions. So her neurologist told her, well, at that point, when you hear the voice and you feel the urge, it's too late. You have to start earlier. You have to start already when you sense something is different, when you get the sense you're going to smell something, and then you use a different smell. So you have a conscious activity instead of one that is being imposed on you as a result of the seizure. Do it intentionally. So she used a very strong smell, hydrogen sulfide, and if she was able to apply it before she had the internal sense of the sweet smell, every seizure was interrupted. Later she found that other smells, including jasmine, were also effective. Now she was a singer, and if you're on the stage, it doesn't work very well to have to pull out a little bottle out of your pocket every time you get this aura. So her neurologist suggested to her to condition, to add the memory of the smell to a bracelet that she was wearing. So she could see the bracelet only when she also smelled the smell. And that way, every time she looked at the bracelet, that evoked the memory of that smell, and she was able to stop her seizures just by looking at the bracelet. And then finally, she learned just thinking of the bracelet was sufficient to interrupt the seizure from progressing. So that teaches us that maintaining intentional control, remaining in charge of the situation, is essential for preventing the seizure to progress. Gradually, her aura, because she was doing this every time she experienced the aura, she replaced it with the smell. Gradually, her brain learned to generate the smell of jasmine on its own. So her aura changed to consist of the jasmine instead of the sweet smell she had had before. And then gradually these auras stopped as well, and she became seizure-free. So as scientists, we have to ask the question, is this story really true? And also the stories that Donna is telling and the patients that she has been seeing and that you have heard this morning, is that really true what they're saying? Could this apply to me? Well, we'll have to look at the evidence. We did a pilot trial at Oregon Health and Science University to look into this. And if it is true, how can it work? What is the mechanism? Well, to understand this, we need to include both the internal as well as the external perspective. As a first approximation, let's look at another change in consciousness that has a lot in common with the onset of a seizure. What you're seeing there is an EEG, the brain waves of a person who is just falling asleep. On the left side of the tracing, you see the regular rhythmic discharges of the alpha waves, about 12 Hertz per second. Every green line is 1 second of activity. And as you go to the right, you see that those waves gradually tapering out and being replaced by much slower waves and really big waves that center in the center of the brain, where it says CZ, the FZ, CZ, CZ, PZ. That's... yeah, that's right. Okay, so I can use this, this arrow. So here I'm pointing at this central discharge, which occurs for every person once they reach stage 2 of sleep, where we really lose contact with our environment. These waves are starting to occurring in our brain. And as electrophysiologists, we know that these waves are very similar to the epileptic spikes that occur during an epileptic seizure. Also, the ensuing slower activity of the brain that happens during sleep is very similar to what happens during a seizure. And from falling asleep, we know well that we have an influence on it. Of course, when we get tired, there may be a strong urge to fall asleep, but we have the option to resist. If you're sitting in a lecture that may be going on for a long time or be after lunch, it may be there may be a strong urge to fall asleep. I can say, hey, no, I need to listen to this. I need to understand this. I have to stay with it. And then you can overcome that urge. That staying awake against the temptation of sleepiness is very similar to what we need to do to stop an epileptic seizure. So we learn from this that consciousness that we experience every day, the waking consciousness, is not an automatic result of brain state, but is an intentional act. We have to want it. We have to do it, just like standing upright. And these are essential qualities of being human: stand upright and being awake. And some people, like those who have epilepsy, really need to fight for having that and maintaining it. And when we do that fight, when we exert that activity of being awake, that has physiologic effects on the state of our brain. We need to know that. Yesterday the question came about neuroplasticity. This is exactly what it is. What's happening in our brain, the physiology of our brain, reflects what is going on in our mind. Don't let anybody tell you, like even I was surprised to hear Josh saying that our emotions and our thoughts are electrical blips in our brain. That's not true. We have our feelings and thoughts which get reflected in the brain. The brain reflects what we do. And as a result of that reflection, we become conscious. So we need the brain to have those feelings and thoughts, but we don't need the brain to generate them. We need the brain to become conscious. And this is a very complex topic. I'll be happy to discuss with you, and also happy to discuss with the scientists who may be here. It's a revolutionary opposite view of how it's commonly viewed, that consciousness is a product of the brain. I'm telling you, it's not true. And as an epileptic patient, when you have a seizure, you can find that we just need the brain as a resistance to wake up on it. We can shape our brain function the way we need it. This is very important to know in overcoming epilepsy and also all kinds of other neurologic disorders. Brain injury, stroke, multiple sclerosis, autism, and others can be changed. Just look for it and you'll find the books and you find the reports of the people who have done it. This is very important to know, and I think it's going to change the face of neurology over the coming decades. So in the application for epilepsy, we can demonstrate to ourselves that this is actually true, what I just said, by doing EEG biofeedback. If you hook up your brain to measuring the electrical waves that are generated by the brain, we can experience... Is it too close? Okay. Yeah, I mean, this is how close I am. I should stay a bit far away from it. Yeah, no problem. Yeah, thanks for alerting me to that. There's a study done by the Bierbaumer group in Tübingen in Germany showing that 28 one-hour sessions of biofeedback helped patients to become seizure-free. 6 of 18 patients, just by the ability to modulate what's going on in their brains, helped them to become seizure-free. But we know that in the long run, more is needed. This is why we need a comprehensive approach like the Andrews Ryder approach that you've heard about this morning. We need to address our triggers and to learn to recognize the early signs of a seizure, which is when we need to apply this concentration. So we know from physiological observations that there are changes happening in the body before the seizure starts. Heart rate variability changes have been shown by Novak, 1999, about 30 seconds before the onset of seizures. But many epilepsy patients experience warning symptoms well before, even longer than 30 seconds, minutes, or sometimes even hours, or they know on the morning they wake up, I'm going to have a seizure today. In the study that I mentioned before by Reina 97, 50% of the 562 patients experienced the reliable warning symptoms, such as headache, epigastric sensations, dysphoria. 42% had a warning that preceded the seizure by more than 5 minutes. 20% attempted to interrupt, and 10% failed to be partially successful. Using EEG analysis, there are also ways to measure changes that occur in the brain, in this case about 20 minutes prior to the onset of a seizure. The changes that occur in the brain have to do with what is described as neuronal synchrony. That means how the different neurons in different parts of the brain interact with each other, if they're going in sync or out of sync with each other. And this study showed that at the end of a seizure, there is a recurrence of synchrony. So during the awake state, we have an interaction between the different parts of the brain that gets destroyed during the seizure. So what we need to do is to learn to maintain this interaction between the different parts of the brain, to not let it fall apart at the onset of a seizure. We also need to know that seizures can be triggered, as Donna has already discussed this morning. Between 5 to 25% of patients have evoked or reflex seizures, as described by Fenwick, 1994. Seizures do not arise randomly, but in context with environmental or internal triggers, or physiologic triggers. External triggers are mediated by our senses. The best well-known condition is photosensitive epilepsy. About 40% of patients have a sensitivity to flashing lights, be that being in an environment where flashes are being used for entertainment, if it's in the context of a TV show, or if it's just driving down an alley, or for some people even seeing a striped shirt can trigger seizures, and that activates the occipital, the back part of the brain. But even more common than that are the internal triggers, the emotional triggers, which at first pass are commonly described as stress-induced, but in second pass we can look much closer. What kind of emotions are there? The anger, the fear, frustration, excitement, all of them can trigger epileptic seizures. And they stimulate the frontotemporal cortex, the front part and the side part of the brain, which are, in adults, much more common regions to trigger epilepsy than in the back part of the brain. And these trigger situations are the equivalent of getting tired with sleep. That means seizures are a possible but not a necessary outcome of the trigger situations. Reflex epilepsy has been described for conditions involving light, smell, hot water, triggering somatosensory, seizures induced by eating, reading, calculation, spatial decision-making, musicogenic epilepsy. Specific tunes can elicit an emotional response that then triggers a seizure. Or the so-called psychogenic epileptic seizures, which are directly triggered by the emotions. And the place in the brain where the seizure starts may be considered hypersensitive, just as when we have a burn on our skin, a touch that would be a normal touch anywhere else, if you touch that place, will cause intense pain. And so similarly, that part of the brain that is affected by the brain damage that triggers the seizure, if you have anything happen to you, if that's a sensory trigger or if it's an emotional trigger, triggers such a strong response from the brain that a seizure will ensue. Any activation may cause overexcitation. So how can we make use of this? There's a number of groups who have tried to work with this. Donna's not the only one. For example, Peter Wolf, a neurologist who happened to be the professor of neurology at the university in Germany where I trained, where we used holistic approaches in all aspects of the medical field, including neurology. He did a study of 25 patients, all of which had refused to take medication, and 8 of 23 patients became seizure-free for 4 years using his behavioral approach, which is somewhat different from Donna's. I think I'm going to skip over this and just point out that for emotions, there exist regions in the brain, just as they exist for sensory stimuli, that can be overexcited. So here's a physiologic study studying the effect of anger on the top, in the front part of the brain. So if you flash faces of angry people, this is what they did, and then measure the brain waves, and you do this enough times, you can find that there's a change in the brain in the front area on the right side. If you flash faces of fearful people at normal volunteers, you get a response here in the left temporal region. It's on the left side of the brain. Already before this study was done, Donna made her pioneering observations of noticing that there was a correlation between the emotional triggers and the side of the brain where the seizures start. So people who had anger as their emotional trigger for seizures predominantly had their seizure focus in the left side of the brain. Whereas people who had fear as their trigger had invariably their seizure start in the right side of the brain. I think that's quite an amazing observation. And we try to do some physiological tests to better understand this fascinating observation. So here's a brief overview of the Andrews Ryder behavioral approach, which maybe we don't need to go over because we've already discussed it this morning. But one of the principles that Donna has been using comes out of this observation that I just described, that an active emotion such as anger or frustration, something where we want to get out and do something, that correlates to activation of the left brain hemisphere, and more passive emotions such as fear, where we want to retreat, we want to get away from it all, correlates to the activation of the right hemisphere. Now, other scientists, for example, a friend of mine who is studying vision in Australia has found that it is normal, it's part of the normal state of the human being to continuously switch back and forth between utilizing the right and the left hemisphere. You can see this, for example, if you look at something like a Necker cube. I'm sure you have seen this. This is this kind of a figure of a cube that you can variously see with the top, with the front part coming forward, with the right side coming forward, or with the right side going backward. And he says, this is John Pettigrew, that you're using one hemisphere or the other by looking at these two different aspects. And for him, that was associated with emotional control. He himself had a bipolar disorder, or manic depressive disease, and he knew that if you get into a state of depression, you are stuck in the right hemisphere of your brain. If you are getting manic and angry, you're getting stuck in the left hemisphere of the brain. So people who are predisposed to manic depressive disorder are those that switch very slowly back and forth between the right and the left side, and that's why they are prone to getting stuck. So it is very useful also for the treatment, especially for the treatment of epileptic seizures, to learn to switch, to get away from being stuck. Learn how to facilitate, on the one hand, a proactive approach to activate the left hemisphere. For example, if we are having a hidden anger but we can't get it out, we need to learn how to do that. Or if on the other side, people who are out in life all the time, they're the doers, but they can't stop. You know, it's the type A personality. You need to learn to sit back and learn how to do passive listening. What's going on in my life? Activate the right hemisphere so you can also give room to the intuitive capacities that we all have. Our society nowadays is very much focused just on the so-called dominant side, the left hemisphere, but to be healthy we need an interplay between both of them. So one of the practices that I've done with my patients is the practice intentional switching after the relaxation practice, which is a precondition to be able to get to that state of freedom where you can even consider changing your state of mind. With it comes actually a complete change in personality. The left brain and the right brain have a totally different personality, and it's an enormous relief and freedom to be able to switch and utilize different personalities as needed by life situations. So Donna calls this driving the brain, intentionally deciding how to utilize the brain instead of passively being driven by a seizure. And as I was just described, in addition to staying awake and concentrated, it may include intentional activation of specific emotional states. So in our pilot study at OHSU, to see if this can work, we had patients between 16 and 50 years who had at least one seizure per month for 6 months, had to have well-documented epilepsy by EEG or EEG video telemetry, and a low probability of psychogenic non-epileptic seizures. All 8 participants had complex partial seizures. 4 had secondarily generalized tonic-clonic seizures, lasting from 10 to 45 years. 6 had failed at least 2 anticonvulsants. 4 of these had the evaluation for epilepsy surgery, and 2 of them had failed epilepsy surgery, while 1 participant refused anticonvulsants. And what we saw is that there was a drop by more than 50% in the median seizure frequency, taking all the patients together. And this was an effect that was stable long-term, not only during the therapy, which lasted about 6 months, but even 6 months after the end of therapy, where we had no contact anymore with the patients. With some patients, we had up to almost 2 years of follow-up, and they stayed at their improved state. But the improvement depended dramatically on whether patients were actually doing what they needed to do. Scientifically, we call that compliance. And in this slide, you see that only those people who were actually doing had an improvement of 50% in their seizures during treatment and 80% improvement after treatment was completed, whereas those people who did not follow the instructions actually got worse. That difference was highly significant. Everybody who was in the study had a remarkable improvement in quality of life, which stayed stable even until after the end of the intervention. And there was a temporary improvement in quality of life. This slide is worth considering, showing the frequency of seizures on the left side in a patient who was very compliant, as you can see here, in doing their daily relaxation and doing their daily journaling, as Josh was describing. Whereas this patient here on the right, this is a baseline. Then patient entered the study and did the intervention for a short time. Her seizures stopped, but then she stopped doing it, and her seizures came back. The whole time, her medication levels stayed constant. So overall, of the 7 people who completed the intervention, 1 became seizure-free, 1 achieved more than a 90% seizure reduction, 2 others achieved more than a 50% reduction in seizure frequency. And seizure reduction was dependent on compliance and motivation. There were no significant changes in medication or medication compliance, means taking the medication, so we can't explain the effects that we saw by medication. It really was the Andrews Rider intervention. And there was a stable improvement in quality of life and a temporary improvement in mood. So this intervention really holds promise for patients who do not qualify for or have failed epilepsy surgery, have failed anticonvulsant therapy, or are highly motivated to pursue non-medical treatment alternatives. And of course we'd like to do larger studies, and we need to do more research to understand how emotions and also the relaxation technique affect the brain processes in epilepsy patients. Thank you for your attention.